Okay, we're going to go ahead and start. And thank you, audience, for joining us today. For an overview of what the work's done at the South Asian Heart Center, as well as a presentation of the data that Dr. Molina and Mr. Mathur has collected. So a brief introduction. Dr. Molina is a practicing cardiologist here at El Camino Health, and he is the co-founder with Mr. Ashish Mathur of the South Asian Heart Center. Cesar got his bachelor's at Boston College and went to Yale for his medical school. And he went to Stanford for his training, including cardiology. And actually, Cesar was a resident when I was a medical student. So he's a little older than me. And Cesar is very interested in lifestyle medicine and also, of course, coronary artery disease in South Asians. He's also well versed in Ayurvedic medicine and practices transcendental meditation. And I will introduce Ashish when he comes up for his part. Go away.
Well, thank you very much. So I would like to first of all give you a little introduction as to how the South Asian Heart Center started and what have been our accomplishments. It was started in 2006 as a result of the epidemic of coronary artery disease, and particularly heart attacks showing up in the emergency department at El Camino Hospital. At that time, I was an interventional cardiologist, and we would be seeing 42-year-old engineers without any of the typical risk factors for coronary artery disease. Usually there was a spouse waiting in the waiting room with a few kids, and the patient was having an acute myocardial infarction out of the blue. And that led to the interest in this epidemic, El Camino Hospital being the hospital of Silicon Valley. And as a result of a few key individuals, the South Asian Heart Center became a reality. Now, I don't have any disclosures as well as Ashish to report. Let's just go over what our CME objectives are. Our goal is to understand the role of this metabolism and dyslipidemia as drivers of coronary arteriosclerosis. And for that, we're going to have to wait until the end of the talk. We're going to look at the potential relationship between the epidemiology of diabetes and coronary artery disease. Are these two epidemics related with each other? These are epidemics that are taking over India, where 60% of the world burden of coronary artery disease is in India, and about 1 of every 3 diabetic patients will actually reside in India. We'll look at the role of cholesterol, lipids like LDL, HDL, triglycerides, Lp(a), and inflammatory markers like CRP. And that will be interesting because this was unexpected. We look at the relationship between markers of obesity and insulin resistance. Insulin resistance is very prominent in the South Asian population. So how do we define obesity is of very great importance. And then we'll finally go over the role of apolipoprotein B and a ratio that we discovered, published, the non-HDL cholesterol to the ApoB ratio in looking at the severity of coronary artery disease. This is the last paper we published that was published this year in the Journal of American Heart Association. And we'll also introduce another ratio to easily and quickly identify insulin resistance just by looking at the laboratory numbers. So introducing El Camino Hospital South Asian Heart Center, it was founded, like I said, in 2006. Our mission is to reduce the high incidence of diabetes and heart attacks in South Asians with a culturally tailored, science-based, and lifestyle-focused services. Now, initially, we came out to service the South Asian population. Now, the South Asian Center is available to anyone of any ethnic background, and we provide services to everyone, independent of their ethnicity. These are actually our founding scientific advisors. In 2006, I asked them to join us, particularly Dr. Kanu Chatterjee, who is now passed, and who's at that time a very, very prominent cardiologist. I would say the master of all cardiologists. Jerry Reven was his disease. He was also a very important member of our team, and we published multiple papers that I'll show you here today, as well as Dr. Ines, who actually was the first physician in the world to really highlight this increased risk of coronary artery disease among South Asians. P.K. Cha, who is based at Cedars-Sinai, and he brought in his knowledge about HDL cholesterol. And Robert Superco, who at the time was at Berkeley Heart Lab, and who was sort of interested in advanced lipid testing. So these are our present scientific advisors and clinical advisors. The latest addition is Dr. Anu Shirala, who works out of Morgan Hill Gilroy and is now a faculty member at Stanford. And they're actually, these individuals sort of participate with us as we go forward. Now, this is a summary of our engagement. We have been able to reach about 110,000 individuals, reach them through telemarketing, through our web services. We have about 15,000 subscribers to our email list. We have had over 2,000 donors, and we actually, from the beginning, we have been driven by volunteers. So there have been about 2,500 volunteers who have participated in our programs. Many of them actually are high school students. We have had a few individuals who actually have graduated from college and have used us as a jumping board to go into medical school with great success. We have actually evaluated about 10,500 participants. So we have the largest cohort of South Asians under study in the world. We have two locations here, one at El Camino Hospital at Melcor Pavilion and the other one at Los Gatos Community Hospital. We have participants within 38 states, and we have participants within 6 countries. So we actually are a worldwide organization. We have provided over 2,000 CME credits to physicians, and we have had collaborations with multiple other healthcare providers who have referred their patients to become our participants. The South Asian Heart Center does not practice medicine. We actually screen and educate and coach. And therefore, the physicians continue to practice medicine while we collaborate with them, providing those lifestyle coaching services. And finally, we actually have 8 publications that we're going to sort of discuss here today. The last one being in 2023 at the General American Heart Association. Now, this is how we have done in the coaching side. This is looking about to 4,400 participants over a 12-year period. And our event-free survival is 98.7% over 6 years. 63% of our participants have increased their vegetable consumption. 58% of our participants are more physically active. 57% have improved their triglyceride levels, as well as 62% have improved their cholesterol, that is that HDL to their cholesterol to HDL ratio. Now, we also have a Stop Diabetes program. This is a CDC certified diabetes prevention program. And when we look at the first 200 participants separated in 16 batches, we have seen that 68% of them have lost weight over that 1 year of enrollment into our 1-year program. 1 out of 3 participants reached their weight loss within that 1 year, and 7 out of 10 have had a significant drop, about a 10% drop in their hemoglobin A1C as a result of participating in our lifestyle program that encourages meditation, exercise, diet, and sleep. Now, this is how we do it. We have developed this Aim to Prevent, which is a 100% virtual telehealth program that is actually available to anyone with access to the internet worldwide. So we assess for the risks, we intervene with a clinical educator, and then we manage for a year with a clinical coach. And We do this by obtaining a health assessment. We have a health assessment vehicle. We do some laboratory testing. At the beginning of the South Asian Heart Center, we tested for everything because we didn't know what was significant and not significant. We had cut down significantly now, and I'll sort of show you more or less what we test. We have done a very simple exam that is check for BMI, waist circumference, and height. And ultimately, we were the first ones to introduce at El Camino Hospital frequent and routine coronary calcium scanning. And initially, we had the best deal in town. It would cost $100 to get a heart scan at El Camino Hospital. Now it's about $158. But that was a source of referral from many other practitioners, particularly the Palo Alto Medical Foundation was able to use that excellent price point to make heart scanning available to their patients. And we go through a review process and recommendations. This is actually what we provide. We provide a program that includes stress reduction with meditation, an exercise routine recommendation, a dietary recommendation, and sleep. And this is all science-based. For all of these 4 things, we have a knowledge base and educational material that is provided in a lecture format on the science behind meditation, the science behind exercise, the science behind our nutritional recommendations, and the science behind our sleep recommendations. And this is actually how it goes. After that 1-year program, we then go back to all our participants and we actually we obtain outcome information. That is, we recommend that they retest their blood again, and then we actually find out if they have had a cardiac event or not. And that's how we then can see how effective we are in preventing cardiovascular events and major morbidity and mortality. We are in the process of actually doing that right now. So this is ultimately as a result of what we have learned. This is how we now deploy our program. We have an ABC approach to this, very simple. We look for the atherogenic profile. This is laboratory testing. And here, we mainly pay attention to the non-HDL cholesterol to ApoB ratio. We have found that hsCRP, Lp(a) are not predictive of the presence or severity of coronary arteriosclerosis, and I'll show you that data later on, as well as the lipid panel. They are very important because they have been shown to be associated with heart attack, but not associated with the presence of coronary arteriosclerosis, at least in our data set, in the MESA data set, and in the Masala data set, and in multiple heart scanning data sets that have been published. Those 3 items have not been shown to be predictive. We also have the B, so we really very much pay attention to the behavioral profile of our participants. We pay attention to smoking and alcohol addiction, levels of physical activity, serving of vegetables or fruit, and hours of sleep and stress management. We don't ask our participants on how many servings they consume. We have translated it to fists. So 1 fist is 2 servings of vegetables. 1 fist is 2 servings of fruit. So because everybody has a fist for the most part, and no one walks around with a cup to measure a serving or half a cup, we have actually used that language within the South Asian Heart Center, and we strongly encourage everybody else to do so. And ultimately, we evaluate their cardiometabolic profile, and we pay attention to blood pressure, fasting blood sugar, hemoglobin A1C, insulin levels, central obesity, in this case, the waist to height ratio, their BMI, and the presence or absence of insulin resistance as assessed by the triglyceride to HDL ratio. We have also come and developed this as a little shortcut to making the diagnosis of metabolic syndrome. And I'll show you some data on that. So through the last 16 years, we have identified shortcuts in identifying metabolic syndrome and the presence of coronary calcification. So we discussed what our CME objectives, but what have been our research questions? First of all, we had to define our research cohort. Our research cohort is made of highly educated South Asians who are actually considered to be healthy and may not represent the whole South Asian population, but we had to then identify who they were. Then we also had to come up with a definition of obesity. And unto us, there was really no scientific data to identify obesity within the South Asian population. Most of the studies looking at obesity in the USA were in data sets that did not include significant number of South Asians. We then looked at the prevalence of metabolic syndrome in our cohort, and then we subsequently looked at the interaction of risk factors with metabolic syndrome, as well as the interaction of risk factors with coronary calcification or coronary arteriosclerosis. And we were also then able to use with machine learning and artificial intelligence, come up with beautiful ways of seeing how things interact with each other. And if we have time, hopefully we'll get to that. So here's a list of publications. We're not going to sort of read them right now, but I've included them in the presentation because this presentation will be available in PDF format. And if you want to go back to the literature and fact check us, I would highly recommend you do that. The latest paper was published in the Journal of American Heart Association. And as a result, we have been invited to Thailand to present this data. And we have been invited to Paris to present this data in an artificial intelligence conference. So let's just go over the biometrics, the lipid levels, metabolic factor, the genetics, and inflammatory markers as we establish our baseline. So that actually, there was a paper that was published by Anita Sati, who is the person who runs our coaching program, along with Elena Flowers, who at the time was a PhD candidate at UCSF under the guidance of Jerry Reven. And what we found was that about 2.6% of our cohort had a personal history of coronary artery disease. And those individuals were actually excluded from the data I'm going to be showing you later on because they're not the healthy cohort that we are now here to discuss. 10% of them had a personal history of diabetes. 21% had a personal history of high blood pressure. 29% had a personal history of coronary artery disease. And not surprising, 51% of them had a family history of diabetes. And that was very sobering because there is a big epidemic of diabetes in the South Asian population. When we look at the Masala trial, just the baseline data of that set, about 47% of the participants in the Masala trial had diabetes or hyperglycemia. Now, hypertension was found in 37% of the participants. Only 17% of them knew that had high blood pressure and were treating the high blood pressure when they came to see us. BMI was elevated in about 51%. That is, the normal BMI for a South Asian or any Asian is a BMI below 23. And 51 had a BMI between 23 and 27.5. South Asians with a BMI over 27 are considered to be obese. And 26% were obese. 18% of them were hyperglycemic. 12% of them knew that they had diabetes. And only 8% were on their diabetes treatment. The 10-year ASCVD pool cohort risk in our population over 7.5% was 41%. That is 41% met the criteria right off the bat for statin therapy. But I'll discuss this further because we actually compare this formula with the presence and severity of coronary arteriosclerosis. And this formula is insufficient to discern between individuals who need or do not need statins, particularly our South Asian ancestry. This is how we compare ourselves to NHANES. LDL cholesterol is no different between our South Asians and the NHANES, which is representative of the American population. HDL cholesterol was significantly lower in our cohort than in NHANES, by about 9 milligrams per deciliter. Triglycerides were slightly higher. The total cholesterol to HDL ratio, HDL being lower, was significantly higher in our cohort than in the NHANES population. ApoB, a representative of LDL cholesterol, non-HDL cholesterol, was the same between both populations. Fasting blood sugar, interestingly, was lower in our cohort than in the American NHANES data set. And CRP was significantly higher in South Asians as compared to the NHANES population. You can see that NHANES is made of 1,200 subjects. This data set included 4,000 subjects of South Asian ancestry in our group. When we look at systolic blood pressure, it was not significantly different, but it was significantly different when we look at diastolic blood pressure. And diastolic blood pressure seems to have a significant role in coronary arteriosclerosis, and I'll show you that later. BMI was actually lower than in the American population, BMI of 26 versus 28. 26 in South Asians and 28 in the NHANES make both groups overweight. And waist circumference was less in the South Asian population and was significantly less than in the NHANES population. Now, then the question is, because it's a very important question, is BMI good enough to identify the risk for metabolic syndrome? Or do we have to use other parameters because of the importance of central obesity in insulin resistance? And it is not uncommon to see South Asians with diabetes who have actually normal weight but have a belly. So the question then was, which are the factors that we can use to identify metabolic abnormalities? That had been evaluated in the overall US population, but not in South Asians. That data set did not include South Asians, and this has never been answered before. So we went ahead and did this. This was done in collaboration with Fahim Abiasi and with Jerry Reben at Stanford. So we tested the hypothesis that the association between body mass index, BMI, insulin resistance, and cardiometabolic risk factors is comparable to that seen with waist circumference and waist to height ratio. And we actually, both in South Asian men and women, we published that. So what we found was that they actually are very, very much related both in men and women. The Pearson coefficient here was 0.87 in men and 0.82 in women. It was very, very close relationship between waist and waist to height ratio and BMI. But when we actually look and compare it with the 75th percentile of the insulin level or the 75th percentile of the HOMA-IR, which is a measurement of insulin resistance, we found that body mass index and waist circumference was very, very similar, related to insulin as well as HOMA-IR. Now, this is actually in a population, in a large population. There are individual cases where that may not be the case, but in general, we believe that body mass index is good enough to actually identify subjects that are at risk for insulin resistance. And this is actually what our data showed. Now, we then wanted to sort of look at the role of adiposity and cardiovascular risk clustering. So we wanted to ask, the question was, is abdominal obesity better in identifying metabolic abnormalities or this metabolism than BMI or weight? And this actually was published by Elena Flowers along with Jerry Reben and Ashish and myself. And this was what we showed. This is actually how we defined or definitions of metabolically abnormal individuals were individuals who had 2 or more of the following risk factors: blood pressure greater than 130/85, glucose over 100, triglycerides over 150, HDL cholesterol is identified there. And these are actually factors that go into making the diagnosis of metabolic syndrome. And what we found was the following, is that 41% of the sample was metabolically abnormal, and 12% of those, were actually normal weight. And that's how I highlighted it here in number 2 on both waist circumference and body mass index. That you can see that 12% of these individuals who were metabolically abnormal have a normal BMI. But there was a significant individuals who actually that were overweight. When you look at waist circumference as a measurement, you can see that about 35% of those individuals had normal waist circumference, but still were metabolically abnormal. So we showed that actually the waist circumference, at least in this case, is equivalent and is definitely not inferior or superior to just measuring for body mass index. Women were more likely to be metabolically unhealthy at a normal level of adiposity, meaning abdominal waist, whereas men were more likely to be unhealthy with increasing adiposity. So like in other ethnic groups, there are many, 12% of the cohort, South Asians who actually were normal weight, but were metabolically abnormal. Now, the next question is, can we find a clinical shortcut to determine insulin resistance? And working with Jerry Reven is a lot of fun. I mean, he would come up with these questions, and we had this big, huge cohort these questions were very easily answered. So the question is, we know that the prevalence of insulin resistance is associated with dyslipidemia, that is associated with high triglycerides and low HDL cholesterol, and that those abnormalities are increased in South Asians. We know that the plasma concentration of triglycerides to HDL cholesterol has been proposed in other populations as a way to identify presumably healthy individuals who are at cardiometabolic risk. So we applied this equation to our cohort and separated them on the basis of HOMA, IR, and insulin levels. So we look at the top 25% high insulin levels in our cohort, and we look at the top 25% insulin resistance according to HOMA. And then we compare it to the triglyceride to HDL ratio. This was published, and these are our findings. We can see that for a man, a triglyceride to HDL ratio of greater than 3.5 identifies 75% of the subjects who were in the 75th percentile or higher on their insulin level, and 77% of those who had on the top 25% of insulin resistance.
In progress.
The same was true for women. So anyhow, so for women, the ratio was 2.5, and for men, the ratio was 3.5. So the typical lipid panel, you get a triglyceride level, you get an HDL, you make a very simple division, and you can identify with pretty good certainty the presence of metabolic syndrome as defined by insulin or insulin resistance. Now, metabolic syndrome is a bad syndrome to have. This is a slide that shows the mortality, the survival probability over time if you have metabolic syndrome. That is, if you have 1 or 2 risk factors for metabolic syndrome in the red, and if you have metabolic syndrome associated with type 2 diabetes mellitus, you see that the mortality rate is over 50% over 200 months. It's not a good thing to have. Now, there's a worldwide difference in the presence of metabolic syndrome. and the incidence of metabolic syndrome. And the problem when you look at the literature is that the presence of metabolic syndrome is age dependent. It will be less likely to find metabolic syndrome in a 20-year-old than in a 70-year-old. So you have to be careful when you're comparing populations. Here, I'm just showing data from the World Health Organization looking at India, showing that in subjects, in individuals over the age of 20, they actually did not seem to have a very, very high incidence of metabolic syndrome as compared to Iran, Europe. And most interestingly, at the end, you see the presence of metabolic syndrome in the USA. In the USA, feathered Indians or American Indians actually have the highest incidence of metabolic syndrome, and metabolic syndrome in the US population is about 38% in both men and women. In India, it's said to be about between 10 and 20, but the problem is that the Indian population is mainly young. They are mainly, you are looking at a youthful population versus a more mature population in Europe and in the USA. But this is our data for a population, and I'll show you that in a moment. We wanted to how to best define metabolic syndrome in South Asians. There are many, many different ways of making the diagnosis of metabolic syndrome. We have actually settled with the harmonized or the International Diabetes Foundation definition. And we wanted to sort of, within our cohort, look at the distribution of metabolic syndrome by components and what are those factors that go into play to make the diagnosis of metabolic syndrome within our population. And we made an attempt to compare what we found with other studies. So this was published in 2010. And this is actually our criteria. Our criteria actually uses abdominal waist as a measurement of obesity. And it gets modified and this is why we use this definition, because it's modified for South Asians. It separates the ancestry from Africa and Europe from the ancestry from Asia, where for men, a waist of greater than 35 inches or 90 centimeters, really 35.4, and women, a waist of 32 inches identifies people with abdominal obesity. And with this definition, this is what we found. Within our cohort, we found that 27% of our cohort had metabolic syndrome. 59% had a normal waist circumference. Now, this is, I think, the most interesting slide. The most common clinical risk factor that made the diagnosis, along with waist circumference, which waist circumference is critical to then enter into the equation. Obviously, we have been trained by Jerry Reven, so metabolic syndrome is considered to be a consequence of that, of obesity, of insulin resistance. It's just not you just add blood pressure and HDL and triglycerides just by themselves. It's really considered to be a complication of insulin resistance or obesity. So here we found that the largest abnormality in our metabolic syndrome group was low HDL cholesterol and high triglycerides. And that accounted for 16% of the individuals who had metabolic syndrome. Then we this is with three risk factors that make the diagnosis along with waist circumference. If you add 4 risk factors, you can see the data there, and then 5 risk factors, where 3% of our cohort had all 5 abnormalities along with waist circumference. This is how we compared with other cohorts that have looked at South Asian populations. And we actually, we don't have the lowest percentage, where we don't actually have the highest. You can see that Bangladeshis who have an incredibly high incidence of diabetes had the strongest incidence of metabolic syndrome. But this is actually with just 91 subjects, and all of them were men. When you look at bigger data sets, we're talking at ranges between 26 and 38%. Um, Now, how do these factors interact with metabolic syndrome? That's the next question that we went out to answer. We looked at Lp(a), CRP, and homocystinemia. This is at the beginning of the South Asian Heart Center. So we were trying to identify these markers, which were thought to be significant in the epidemiology of cardiovascular disease in the South Asian population. So that was published. What we found was that in this cohort, where there were 253 subjects in this smaller study, we found that there was 25% of the cohort, actually 253 subjects had metabolic syndrome. We then looked at a positive relationship between metabolic syndrome and homocysteine, and you can see that here. That as the larger, oops, sorry. That metabolic syndrome, that elevated homocysteine levels were actually the larger the number of factors associated with metabolic syndrome, the higher the concentration of plasma homocysteine. The same was true for CRP. The more factors that make the diagnosis of metabolic syndrome, and there are 5 factors, the higher the HRCRP. But the interesting thing is that there was an inverse relationship between Lp(a) and metabolic syndrome factors. The more metabolic factors abnormalities you experience, the lower the Lp(a). And that's been unexplained, but subsequent papers have also shown that relationship in the epidemiology of type 2 diabetes mellitus. There's an inverse relationship between Lp(a) and diabetes. I assume that if you have high Lp(a) and you have metabolic abnormalities in uterus that predispose you to diabetes, you probably don't get born, because Lp(a) is actually a marker that is associated with infertility. But that's just a presupposition. I am making that up. Now, let me just give you a brief summary of what we have discussed so far, because I've shown you a lot of data. That first take-home message is that body mass index predicts this metabolism as other measurements of central obesity, such as waist circumference and waist to height ratio. And why is this important? Because everybody gets a height and a weight at the doctor's office, but the calculation, the measurement of waist is fraught with error, and most physicians do not measure their patient's waist. So, but we actually have to measure, BMI has to be included in the medical record as one of those quality measures. So every medical record has a BMI. And we've shown that, BMI is good enough. We found that the triglyceride to HDL ratio identifies insulin resistance as well as the ATP3 criteria for metabolic syndrome. That there's a positive correlation, and this is not new, between homocysteine, CRP, and metabolic syndrome. It's new because we identified it in the South Asians for the first time, but it's widely known in other populations. What was new is that there's an inverse relationship between Lp(a) and metabolic syndrome, and we were the first ones to publish that. Now, our goal when we started the South Asian Heart Center was to identify the factors that explain the increased incidence of coronary arteriosclerosis in South Asians. And for that, we incorporated very early on coronary heart scanning, because it's a very non-invasive way, an accurate way of identifying individuals who are asymptomatic, but who are at risk of coronary artery events. And there's a lot of beautiful data showing the relationship between coronary calcification and the risk of heart attack. In fact, there's greater number of subjects in those studies than there was ever in the Framingham trial and all the other studies that have used other clinical parameters. So we actually attempted to adjust for anthropometric, clinical, and lifestyle factors because they actually they failed to fully explain the risk. And there are multiple papers on that. And the problem is that these factors may not have linear relationships. They may have complex nonlinear relationships, and they're not captured in the typical statistical analysis of these factors. So our question was, can machine learning algorithms either identify and model the complex nonlinear interactions of potential predictor variables in the severity of coronary calcification in South Asians? So we actually, that's the question that we asked. And we got to answer in this paper that was published this year. And we identified another equation, another simple formula that helps us identify the increased risk for coronary calcification, at least in South Asians, and we're looking at other populations currently. So this is actually from a paper that was published recently, and this was published in Circulation, looking at the United Kingdom Biobank co-prospective cohort study and comparing the presence, the incidence of heart attack in the South Asian cohort versus the non-South Asian cohort. And this is actually a pretty large study. And what they found that when you look at the typical risk factors, when you look at the anthropometric risk factors, when you look at lipid factors, when you look at the ASCVD full cohort equation, or when you look at the quick risk, which was developed in the United Kingdom and thought to be much more accurate than the ASCVD because it takes into consideration your zip code, for example. They found that there was really no discernible difference between South Asians and Europeans, as you can see in panel B and C. But the incidence of coronary events was still significantly higher in South Asians. So until this moment, we had really no understanding of what was driving this. In this paper, they did note that South Asians tended to have a higher incidence of hyperglycemia and metabolic syndrome and other non-lipid parameters, which don't go into the ASCVD risk pool cohort equation or into the quick risk equation. So we analyzed 1,100 participants who had entered the Aim to Prevent. So we looked at the first 1,100 participants who had CT scanning at the South Asian Heart Center. We analyzed, remember at that time we were testing for everything. So we analyzed 50 prospective variables and we put them into this artificial intelligence machine learning algorithm. And we performed booster regression trees to model their relationships with the severity of coronary calcification and to model the relationships between themselves. We selected branch regression trees because they have the ability to handle many predictor variables. We're dealing with 50. They accommodate collinear variables, things that go along together like BMI and waist circumference. And they can model nonlinear relationships, and I'll show you the nonlinear relationships that came up. And they can also deal with missing observations. And this is actually what we found. This is just doing the simple statistics between 0 score and non-zero score. We found that that the people who were actually had non-zero calcium scores were older than those who had 0 calcium scores. We found that smokers tended to have a higher incidence of non-zero calcium scores. And we found that the presence of personal history of diabetes, hypertension, and even a personal history of cholesterol was associated with a non-zero calcium score. Family history was associated, and being on medications for diabetes, high blood pressure, and high cholesterol was associated with a non-zero calcium score. Now, please realize I'm using the word non-zero calcium score. So that could be a score of 1 or a score of 1,000. The next question, because 0 is different from 1, but 1 is a non-zero, is very different from 1,000 calcium score. So we wanted to really look at factors associated with severity of coronary calcification, because the severity of coronary calcification has a linear relationship with the incidence of heart attack. So this is more of the same. We found that non-lipid factors like blood pressure, fasting blood glucose, hemoglobin A1C, waist to height ratio were able to identify, were actually different in the non-zero calcium score. But which were the factors that were related with coronary calcification? Severity. And these are, out of the 50 factors, these were the only 6 factors that were associated with severity of coronary arteriosclerosis. Obviously, the older you are, the higher the risk of coronary arteriosclerosis. So age was number 1. But that was followed by body mass index. And the fact is that most of the time, we don't think of body mass index as a risk factor for coronary artery disease, but it's a very significant risk factor for coronary artery disease, for stroke, and for cancer. And the data is, there's a lot of data in reference to that, and that's quoted and referenced in our paper. The interesting thing is that the only factor that was related to this lipidemia was the non-HDL cholesterol to ApoB ratio. We came up with this factor because this equation, because it really gives you the concentration of cholesterol per ApoB particle. It gives you the concentration of cholesterol per particle of non-HDL cholesterol. Non-HDL cholesterol is cholesterol minus HDL. That's thought to be the atherogenic component of the lipid panel. And there's 1 molecule of ApoB per molecule of non-HDL cholesterol. It's 1-to-1. So with this very simple division, we can actually calculate a ratio of cholesterol of non-HDL cholesterol to ApoB particles. And we found that to be significant. We found that smoking, that fasting blood sugar, and the diastolic blood pressure were also predicted. And these 6 factors were able to explain 30% of the severity of coronary artery disease. So then the question is, boy, can we only explain 30% of coronary artery disease? And the answer is yes. We can only explain 30% of coronary artery disease. If you look at the literature that predates this paper, that predates the non-HDL to ApoB ratio, the best that can be predicted is 22%. That's sort of quoted in the paper. So we think that we know why people get coronary artery disease, but we can only explain 30%. Now, how do these things interact? These are actually continuous BRT partial dependence plus. So the partial dependence plus eliminates all the other factors, and you're looking at age by itself. So once you get to the age of 55, there's a significant rise in coronary calcification. Once you get to the age of 70, it's nonlinear. If you look at body mass index, once you get to a BMI of 30, it shoots up. Once you get to a BMI of 35, it's nonlinear. If you look at the non-HDL to ApoB ratio, once you go below 1.4, that is, you have cholesterol depleted ApoB particles, you have a significant elevation in coronary calcification. When you're looking at smoking risk, the same. Smoking is bad for you, as you know. This is any smoking in their life. When you look at blood sugar, there's an uptick in coronary calcification after a blood sugar of about 85, 84, and then shoots up after a blood sugar of 110. When you look at the diastolic blood pressure, the blood pressure over 90, just leads to a shoot up in coronary calcification. So now you understand why we come up with these numbers, a diastolic blood pressure of 80 or below, a fasting blood sugar of 100 or 110 over, it is actually, this is clinically what is happening at those levels, at least in South Asians. And this is actually, I think, the most important interaction. we showed you that age is the most significant risk factor for coronary calcification. So then the question is, what modulates the effect of age in coronary calcification? And this is what this figure shows you, that the non-HDL cholesterol modulates the effect of age. So that at any age, if your non-HDL cholesterol to ApoB ratio is greater than 1.4, you have very little coronary calcification. And in fact, that is true until the age of about 58, 60, as you can see in this slide. But at any age, if your HDL, non-HDL cholesterol to ApoB ratio is less than 1.4, you actually see significant uptick in coronary severity of coronary calcification of the coronary calcium score. So that is actually one of the take-home message. Non-HDL cholesterol to ApoB ratio, that is the concentration of cholesterol per ApoB ratio, that is the lower the concentration of cholesterol per particle of atherogenic cholesterol, the higher the severity, or the greater the severity of coronary calcification. This is what we mean by non-HDL cholesterol. That is, the HDL is to the right. Everything else, everything that contains cholesterol minus HDL contains an ApoB particle. So we're looking at the overall concentration of cholesterol in this section of the lipid panel. Now, how does the other ones interact with each other? BMI is a big time effect, has a significant effect. The bigger you are, the more the effect of age. There's an interaction between diastolic blood pressure and age. The higher your diastolic blood pressure, the greater the effect of age. There's a relationship between diastolic blood pressure and obesity. The higher the BMI, the higher the effect of a blood pressure over 80 has in the presence and severity of coronary calcification. And the same is true for smoking. So this gave us an opportunity, because we have coronary calcification and we had the values that go into the calculation of the ASCVD pool cohort score. And we found that the difference between those with a calcium score of 0 and those with a calcium score of non-zero was 6.4 in one group and 3.1 in the other. So even in the presence of non-zero coronary heart scan, if we calculated the ASCVD of that group, it was only 6.4, which did not require statin therapy. But this is just a mean, an average. Now, let's just sort of break it up. So 142% of our cohort, now, excuse me, only 684 participants, which is less than half of the participants, we were able to calculate a pool cohort formula. Why? Because they had an LDL cholesterol greater than 190. So if you have an LDL greater than 190, you don't qualify for ASCVD. If you actually had other factors, like you were already taking statins, they had to be, if you're taking statins, you cannot apply an ASCVD. So half our subjects went into this score. And we found that 21% had non-zero calcium scores, but had an ASCVD score of less than 7.5%. That is, 21% of the cohort should have been considered to be on statins, but would not have been prescribed statins because their ASCVD score was less than 7.5%. 49% of the subjects who had an ASCVD score greater than 7.5% or more had a score of 0. So 49% would have been receiving a statin with a score of 0, and it has been shown that statins have no benefit if you have a coronary calcium score of 0, independent of your cholesterol level. So you would want to treat it, 49% of the subjects, with no benefit. And more than half, 9 of the 15 participants who had an LDL cholesterol greater than 190, which is a trigger to start statin therapy, had coronary calcium scores of 0. So anywhere you look at it, the ASCVD fails to properly classify South Asian subjects. And actually, this is the data. You can overtreat and you can undertreat. So let me just summarize. Our participants who had coronary calcification were obviously older, predominantly male, had smoking history, and had personal histories of diabetes, hypertension, and hypercholesterolemia, and they were on medications for this. When you look at the simple statistics, zero calcium score versus zero calcium score, insulin, body mass index, blood pressure, fasting blood sugar, A1C, waist to height ratio were associated with coronary calcification. But the interesting point is that none, I repeat, none of the lipid panel factors had any relationship with the presence or absence of coronary calcification, including Lp(a). The ASCVD score failed to classify individuals, as I just showed you, and only age, body mass index, the non-HDL cholesterol to ApoB ratio, smoking risk, fasting blood sugar, and diastolic blood pressure were predictive of coronary calcification severity, explaining about 30% of the variability only. And a non-HDL cholesterol to ApoB ratio less than 1.4 or 1.4 or less markedly increases the risk of having severe coronary arteriosclerosis at any age and at any BMI. So in conclusions, our findings highlight the relationship between factors associated with diabetes, this metabolism, and coronary arteriosclerosis, possibly explaining the dual epidemics of diabetes and coronary arteriosclerosis in the South Asian population. The factors that predispose them to diabetes are the same factors that predispose them to coronary artery disease. The presence of cholesterol-depleted particles, as measured by the non-HDL cholesterol to ApoB ratio, may explain for some of the unaccounted increased risk of coronary artery disease in this population. That is to be determined. Therefore, the assessment of cardiovascular risk should focus on markers of glucose dysmetabolism and dyslipidemia as measured by this ratio. Prevention and treatment strategies for cardiovascular disease in this population should be modified to pay attention to improving metabolic health. And it goes back to what is your weight? What is your waist to height ratio? So we come up with the ABCs. This is actually how we come up at the South Asian Heart Center, and we actually highly recommend that you incorporate that into your practice. Look for the atherogenic profile. We have actually called this the atherogenic ratio, the non-HDL cholesterol to ApoB ratio, normal greater than 1.4. Body mass index, look for BMI less than 23 as a healthy BMI. And the cardiometabolic profile, looking at the triglyceride to HDL ratio. Normal is less than 3.5 in men, and normal is less than 2.5 in women. Now, I would like to sort of see if Ashish has a moment and wants to sort of describe a little bit to you how we go about doing the aim to prevent program at the South
last slide, the one after this, Dr. Molina. So what we've done now at the South Asian Heart Center is to, am I on?
Yeah, your mic is on.
Okay, is to just package all of our lifestyle programs and make them available to physicians as well. So you can see that we have offered this lifestyle membership medicine partnership with the South Asian Heart Center, because we've been able to kind of, from the years, be able to kind of structure the lifestyle programs in a way that we can execute with the participants who come to the South Asian Heart Center. So we have built the Aim to Prevent program. We have the Stop D program, the two programs that Dr. Molina talked about. We do have a Slim Fit program. This is focused on individuals who are looking to lose weight and be fit at the same time. And then we've also kind of done a 2-week program to help people understand how the CGM kind of interacts when they are tracking their lifestyle. And this is really very meaningful for individuals to see how different aspects of lifestyle affect their blood sugar levels. Since our focus, Dr. Molina was talking about, is on the glucose regulation and health within these individuals. We also provide a bunch of workshops now, and they are available to the general community. We call it the health huddles, and they are on last Thursdays of every month. And we also do this intermittent and conscious eating. There's a lot of talk around intermittent fasting, and people have questions around how to implement those. So we offer this one class. It happens almost every other month, and it's for 1 hour. And then, of course, the screening for coronary CT scan as well, if you need that for your patients in your office. There is a QR code that they can just go online and be able to avail of these. So that's it for us. Yeah.
Well, I think our time is up, but I failed to introduce Ashish. Cesar, you didn't give me 30 seconds, but Ashish is also the co-founder of the South Asian Heart Center, and he is the creator of the STOP-D program, which apparently has been very, very successful. And I have a question for Cesar. So number one is, the waist to circumference is very important, but we all know that as you get older, your waist gets bigger. So is there an age adapter for that metric?
Actually, no, because as you get older, you have your increased risks you do have more metabolic syndrome, and you have increased risk of diabetes and increased risk of cardiovascular disease. If there is, I'm not aware, but I would not expect it to be corrected, because if you assume that it's getting bigger because you're getting shorter as a result of osteoporosis, then there may have to be some correction there. But what I have seen around me is that it gets bigger, not because you're shorter, but because it gets bigger. And I don't know of any associated formula or way of adjusting.
Yeah, it's a fat distribution as your hormones change. So all women, if you're going through menopause, that's a great disappointment. And Anita had a question, which is how often do you repeat the calcium score? Do you have a recommendation on
if
that?
your calcium score is abnormal, we never repeat it. For us, it's a yes, no question. You have coronary arteriosclerosis or you don't have coronary arteriosclerosis. Now, if you have a coronary calcium score of 0, statistically speaking, that gives you a 5-year free card with the incidence of 1 in 1,000 of an MI within those 5 years. There is actually some literature that says that it really gives you a 10-year card. Now, if your calcium score is 0 at the age of 59, I would not repeat it unless something happens. Or if you actually have been prescribed statins and you don't want to take the statins, or you don't tolerate the statins. But for the most part, if you actually have a calcium score of 0 in your 60s or 70s, I don't believe that there's you haven't had it for 60 years, it's less likely that you will actually catch it by then. But in the other population, we actually recommend that they get tested no sooner than 5 years, and get tested if they had a calcium score of 0 and there has been a metabolic change. That is, they have gained significant weight. They may become pre-diabetic. That is, they don't have diabetes. If they have diabetes, I would not do a calcium score. I would assume that you need to be on statins no matter what, and you should assume that you have coronary artery disease. However, there are some people who do not tolerate statins, and then you need to know how much you push in that person with diabetes. And if they have a calcium score of 0, you push less hard.
Well, I think our time is up. So thank you very much, South Asian Heart Team.
Thank you so much for having us.
All right. Bye now.
Didn't have very much
time.